So I hope everybody's had a good day. I'm certainly dating myself. This is, this CRF Fellows course wasn't this when I finished training. We still had our angiograms on film when I graduated in spools, and there was only one Fellows course for the entire year. It was in San Jose. And I remember visiting that with Antonio Colombo having a projector with spools to show films. And it's evolved into this, and I think this is really, you've got some great fellows education, and I hope you're getting something out of it. So today I want to thank Asahi for sponsoring this lunch symposia. I've got really great partners here, and Dr. Prasada and Dr. Chima. We're really going to talk about wire technology, and I have to tell you that, yes, stents have become so good, but you can't put a stent in unless you could wire a lesion. And no matter what you guys end up doing, whether it be structural, peripheral, or coronary still keeps the lights on in America's cardiology and cath lab programs. Just know that, okay? That's a fact. Now, there's some low-hanging fruit. My brother will tell you that endovascular is the be-all and end-all, and you will get great jobs. But everybody still needs a good coronary operator. And so today we're going to talk about something very fundamental, which is basic guide wire education. And I can tell you that if you're good with guide wires, you're going to be good with everything else. So my name is Manish Parikh, and I took a new role at Brooklyn Methodist from Columbia a couple of years ago. And this was something that I utilized for my staff who are not accustomed to doing different types of procedures. So why is a PTCA guide wire such an important device? Well, like I said, if you can't cross a lesion, you can't treat it, right? And so fundamentally, it's how do you get through and modify and treat with a stent at the end of the day. So there are many PTCA guide wires. There's more than 300, okay? And do you need to know all 300? No. And the thing that fellows make the mistake of is they will learn with certain wires. They will then go to a practice which may or may not have those wires. And the first day, you're not going to start demanding that the procurement office buy the wires you like, because who are you? You're new. So you need to learn families of wires, okay? There are families of wires that all do the same thing, may have different names from different competitors. And as you get more experienced, you'll then have your small family of wires, and it'll be in your lab. Now, I must say, Asahi, when it comes to wires, they're really the creme of the creme. Okay, they have the best technology. The truth story is I used to be a BMW balanced middleweight wire user. It was not an Asahi wire. And about 5-6 years ago, I switched to Xi'an Blue, and it's had its iterations. It is the safest, best, most friendly fellow wire. Okay? And it is actually best in class, and there's a reason for that. You need to understand why, not just because we're here at lunch, but it's the class of wires and what you're asked to do, and when you pull it, that's important for you to know. So why so many? Again, this is, a muddy road. You're not going to take your Ferrari through this, right? You're going to take something different. And here, when you need to go fast and down, you're going to take a Ferrari. And so there's different roads you're going to have to travel. So what's in a basic wire construction? And you will never imagine what a wire really is that you take out of this package, right? And use once and throw away. How much it goes into constructing it. And most of it, even in this day and age, is manual, okay? And it's pretty impressive. So there's a core. That core element will be of two materials, either stainless steel or nylon. And the tip load is how stiff the wire is at the distal end when it's put in a a loading dock, and how much is deflected 2 millimeters, as Margaret said this morning, and it comes in grams of tip. Then there's a coil. There are many different coils, and we're going to talk about why the coil is so important. And then there's a coating on top of the coil. Okay, it could be very lubricious or not lubricious, depending on what it is you're trying to do. So tip load, core, coil, and coatings really give you the feel and function of the basic wire. Now, it seems very simple, and why isn't every company have the same wire? Because it just doesn't. It's like, why isn't every car the same? Or why isn't every stent the same? It just is not. So again, the tip load, as I said, is 2 millimeters of deflection as it's anchored, and you have from 0.5 grams all the way, as Margaret said today, to 20 or 40 grams for periphery. Okay, 40 grams. It's a spear, right? Right? So very different tip loads of force or power in order to cross a lesion. So this is how it's done. You know, it's a 2 millimeter deflection in the guide wire. It's a 10 millimeter portion of the wire, and that's how they measure tip loads. This is the important slide. These are your common wire. You're going to, by the way, you'll have these slides, so, you know, you're going to need to know your most basic go-to wires. What's comfortable in your hands? What does the job without causing problem, right? What are those problems? Dissections, perforation, right? So for me, my workhorse is a Luncheon blue, okay? It's the safest, okay? It is 0.5 grams. The Menominal you're going to hear about, like I said, BMW Universal and BMW, and the Universal 2 used to be my go-to. A little bit, nitinol wires, a little bit more gram strength. When I need a second wire, got an LAD diag, LAD circ, I pick a Luncheon. Okay, you'll know when and why you use that. Pro Water, Luncheon Black are different wires for different purposes, and then you've got the Choice family, the Pilot family, and you've got different tip loads, but they're very, very different wires. So here it is, the effective tip load. What is important to know is any wire with a support catheter behind it increases the tip load significantly. So you take a Luncheon blue and put a micro catheter behind it, and all of a sudden it's a very different tip load. Here you've got a Fielder XT, you put a catheter behind it, it's now 3 grams, okay, of a tip load. So that can change with what you support yourself with. Now there's concept of tapered tip and a non-tapered tip, okay? Tapered tip is a Fielder XT, which starts as a 14 1,000ths wire and tapers to a 9 1,000ths wire. The Luncheon blue is 014 throughout, okay? And they have different reasons you're going to utilize them. Now here's a Confianza Pro series and a Miracle Pro series. There's also how it's tapered. Now this thing, right? This Confianza Pro is a spear. It's to penetrate the 12-gram force wire for complex CTOs to penetrate the anterior or proximal cap, right? Whereas a Miracle has much more feel, but it doesn't have that sphere. It's a blunt tip, okay? And so you're going to use them differently. So flexibility and support. So the larger the diameter, the more supportive. This is a very commonly used supportive wire to deliver devices down, the Grand Slam. The smaller the diameter, the more flexible. This is the Luncheon, and I'll talk to you about what Act 1 is in a minute. There's also shorter taper and longer taper, okay? The shorter taper is really more for the supportive wires because you want the bulk of the meat of the wire, allowing you to have devices traverse, and then the longer taper are more flexible wires. And then there's going to be a spring coil. And the spring coils can be either 28 centimeters or 4 centimeters, again, depending on the amount of support. So all this goes in without you thinking about it. But there is a manufacturing that goes into it that allows you to do what you're going to want to do. Now, the spring coil is very, very unique with Asahi. And you need to have a coil because otherwise all you have is a blunt, straight instrument. It won't be able to flex and go around sharp bends like this without causing damage. And so the coil becomes very important. And then there's coatings. As was suggested this morning, there's hydrophobic, hydrophilic, and then there's hydrophilic with polymer jacket, which has the most lubricity but the least tactile feel. Okay? So again, every wire is going to have a different composite of what it is you're using it for. And here you have Miracle Bro. These are hydrophobic, have really the most tactile feel. You will be able to really traverse a CTO body with a Miracle Bro 3, 6, or 9 gram, and you will be able to feel as it goes through. And you'll know if you're subintimal or not, because it will react back to your fingers so that you'll know that you're in the wrong place. Okay? Whereas the Xi'an Black, beautiful wire, you push, it goes. And you hope that it's in the right place, right? Not the pericardium, the right place. But again, it has a role, and it will maneuver through channels and areas where many wires otherwise would not. And then the Xi'an is in between, and it's really for septal surfing, and I use it as a workhorse now. As I said, if I'm doing an LAD diag bifurcation and I need a second wire, one, it's got beautiful tactile feel, and two, it's a different color than my Xi'an blue, right? So I don't want two wires with the same back-end color because I don't have a label on them. I need to know which one is which, right? Some people bend a little bit of the wire. Some people do different things to know which wire is in which vessel. Sometimes you'll have 3 wires. You'll have the LAD, the diag, and the circ if you're doing a left main. Well, it's important to be safe, but it's also important you know which one is which when you're working. So hydrophobic, like I said, it's wax-like when it's wet, and it really provides great tactile feedback. Hydrophilic, when it gets wet, is very slippery, and it will slide through the vessels and a lesion. And when you really have a coating on it, then really it's like a Manama or Xi'an Blue. It gives you the best of both feedback as well as getting through lesions. And then a polymer jacket really is very gel-like and smooth. And as I said, these will track and slide through tortuous vessels, heavily calcified lesions. It's a great wire for microchannel as well. And it has true one-to-one torque. Now, you might say every wire has one-to-one torque. That's not true. What your fingers do with a torquer, okay, is what your eyes should see at the tip of the wire. And not every wire will have that. And as you start doing more and more, you'll convince yourself because your brain will tell you which way to go, your fingers will do it, and then that wire will do exactly what your brain and your fingers are telling you. That's the beauty of the wires we have now. So this is just a micrograph of what this looks like. So what's so special about Asahi? Why are we here? Well, they've fundamentally integrated a production system of wire drawing technology, which controls the strength and the wire diameter, a wire forming technology, which really allows micron size wiring, and also torque response, and then a resin coating technology, all of which is proprietary and engineered through the Japanese company. And really, this is the wire forming technology that's, I think, so cool and makes it different. You actually have several wires melded into one, okay, through this technology. And I'll show you the composite of what is really the Act 1 wire. No other company has this type of wire technology. So Act 1 is Asahi's unique technology, and it really allows for precise torque response, tip shape retention, and durability, which is what you want. You don't want the wire to get mangled and not be able to use it. You want to be able to reuse it and torque it, and you want it to be durable and allow devices to go down it. So here is a cartoon. This is what happens, the top is what happens often with your BMW family of wire. It's that whip. You're trying to come around, get into a circ, get into a diag, and it goes right around. Whereas the bottom is the Asahi technology, which really has one-to-one, and it's not going to have whip. So what your fingers do with a torquer, and again, people ask me, do I need a torquer? Can I just do it with my fingers? Use a torquer. You're going to have much more fine movements than just with bare fingers, okay? So this is really the guide wire technology. You have either corded tip or a shaping ribbon. Asahi has something very, very different, okay? You basically have significant iterations which make it the wire it is. I don't know if this... You have an outer coil, and Act 1, you have a twist wire with a wire core, and then you've got this Act 1 multiple wires and an outer coil that goes on. And here's a really good demonstration of how this wire gets put together. Really, really remarkable. And it's the only way to do justice what happens. Don't cut me off. Here. So this is very different than any wire that you've got. So you've got the outer coil, okay? You've got this twist wire. You've got the high tension stainless steel core. Can we go back and finish this? Got plenty of time. We could just turn off the timer. All right, so you have the out, and then you've got this twist wire, and then you've also got the Act 1, not only the stainless steel core, but you've got this Act 1 wires that are twisted along, which prevent the torque from being so sloppy. So this is a technology that we've never seen before. And when I started using this, I didn't understand why it was so good. But it's because it's engineered in this way to have all these different products put into one wire. Every one of these steps is manually put together. Okay, and you know, this is why, this is the beauty of this wire itself. So really, in summary, it's the tip load, the core, the coil, and the coatings. The wire task will depend what wire you pick with the wire properties, and that's what's going to make you successful. We're going to see some cases with these types of wires. I think Xi'an blue, you will never go wrong. You will not hurt the patient. You will not cause a perforation downstream, and you will find it to be durable so that your attending is not yelling at you or mangling it and needing a second wire like you will with other wires. I think the Fielder XT is really for micro channels. The Grand Slam is your support wire. The Asahi Xi'an is for tortuosity, and the Xi'an Black is similar to Fielder XT with much more one-to-one. Just this slide here will really accomplish probably 90% of all your cases, okay? And if you don't have Asahi in your lab when you graduate, you'll have equivalent for all of these buckets that you'll be able to utilize. It may not be as good as Asahi, but eventually you'll get your key wires that you get very good with and familiar with and it'll be safe for you and the patient. And there I'll stop and take any questions. Thoughts? And we have a little bit of time before we go on. Any questions from the audience? You're going to hear that, so I'm not going to steal his thunder. Okay.
Stay tuned.
That's coming up. Thank you for that intro. So again, please don't go back to your labs and say, I got to have Xi'an Blue, because I'll get a phone call from an angry program director. You have certain workhorses. Get familiar with them, know their pros and cons, make sure you can do most of your cases with it. Try all your workhorse wires, okay? I'm not taking anything away from run-through. A lot of people like run-through. I don't like run-through. Nothing wrong with BMW Universal, great wire, okay? But for me in my lab, Xi'an Blue has got 80% of the workhorse market for the reasons I just showed you. Okay, Dr. Prasada, you're up. So Sahil is going to talk to us about the Manamo wire.
All right, I'm Sahil Prasada. I'm a current interventional fellow at University of North Carolina in Chapel Hill. I have no disclosures. I'm from North Carolina, so I went to medical school at Wake Forest, did my internal medicine and cardiology fellowship at University of Florida in Gainesville, came back to North Carolina for my interventional fellowship, and I'll actually be joining North Carolina Heart and Vascular at UNC Rex in Raleigh. My focuses will probably be coronary and endovascular, including PE. I'm not getting any structural training this year. And so we're going to take a closer look at the Manamo. That's our workhorse wire that we use at our institution routinely, mainly just because of its safety. It has really a traumatic tip, and it's a really safe workhorse wire. Ideally, you want a workhorse wire that has good torqueability, more durability, and a really soft tip load, so you can be as atraumatic as possible. And another reason that I like the Manamo guide wire is that you're able to reshape the tip. So if you're doing multi-vessel PCI, or if you anticipate a bigger bend, you need one in the middle of a case, it's very easy to reshape it, compared to like a run-through, it's a little bit more difficult. And so the Manamo guide wire, like Dr. Parikh had talked about, has a stainless steel core in the proximal end, and then there's a nitinol mesh in the middle part of it, and then it has that Act 1 stainless steel round press core at the tip. So it really has a hybrid. The nitinol is highly flexible, highly durable, low pushability. The stainless steel allows it to be shaped very easily, has a good torque response, and high pushability. So the combination really gives you the best of both worlds. Where I was at the University of Florida, we used a run-through guide wire for most of our interventions. And you'll notice that you have a lot more torque whip with that, like that animation that Dr. Parikh had showed. And I've noticed less when we're using the Manamo guide wire. And part of that is due to the Act 1, which is at the tip. And one thing I wanted to mention, so the Act 1 doesn't actually affect the tip load. The tip load is still 0.5, which I think is a big differentiator when you're looking at workhorse wires. And so then this slide actually kind of shows that there's that stainless steel round press core at the tip with Act 1, which again we talked about helps with the torque and ease of shaping. And then there's that nitinol core, which allows for ease of advancement. And then there's that stainless steel at the proximal end. Ultimately, I do think that, we're all fellows. So like when I was first starting off, wiring these lesions would probably take, 20, 25 minutes. And I do think that with the Manamo guide wire, you may be able to be more efficient in a case when you're going to practice, just because it is easy to reshape. You're able to get the bend that you want. You don't have to get another wire. And you have more control with the wire. And just to kind of recap, there is that 0.5 tip load, which is very atraumatic. There is a silicone hydrophobic tip, which allows you to have really good tactile sensation as well. And then also there's that hydrophilic coating otherwise on the proximal end. And so for shapeability, there's an animation here. Let me see if I can play that. So ideally, when you shape this wire, you would do it with stripping. You wouldn't put it inside the introducer and tip it. because you may damage the Act 1 if you do it that way. Personally, honestly, I've never used the shaping tool that's come with the Manamo guide wire. That's the pink one there. I just use the introducer, and I just strip it, and it's been okay. For most workhorse bends, I usually go for a C shape, and it's been fine. But I do think that the shaping tool that they give has a tapered tip, so you can get a little bit more precise with your tip if you need to. And then there's a radio opaque portion, which is about 30 millimeters of the guide wire. And you can see that tapered tip here where you can get more precise shaping, or you can use a thicker proximal section if you want to do bigger shapes. And again, you should not put it through it like some people do with the introducer that comes in the PCI kit. So overall, Manamo is an atraumatic workhorse guide wire. It's 0.5 tip load. It's very safe to use. You can reshape it very easily, and it also exhibits a higher shape memory when compared to like a run-through, for example. That's really the other guide wire that I've used previously in the past. And it's a very similar support profile to the other workhorse wires. And so I have a few cases I wanted to show. Sorry, let me go back. It's a 63-year-old male, had prior PCI, hypertension, BPH, COPD, came in with chest pain, was transferred to our institution for a left heart catheterization. He's on good medical therapy, as you can see some antianginals down there with Imdur, Toprolol, and he's on aspirin as well. And so we took a picture of the right coronary artery, and as you can see, there's that mid-RCA lesion, but it's a very tortuous distal RCA. And so we were actually very easily able to get a Manamo guide wire down, and it really was not a struggle at all. You figured it might be a little difficult getting past that tortuous bend in that distal RCA. But this case ended up taking about 15 minutes where we were able to balloon, stent, post-still, and it went by much quicker. So I thought this was a great example to show that you can use it even in tortuous vessels. It's very atraumatic, and it made our procedure probably more efficient than if we had tried a different guide wire. And then this is a second case. So this is a 61-year-old male, just has a Lima to LAD, came in for unstable angina. He was seen by a cardiologist at an outside facility, and came in for planned PCI to the mid-LAD via the graft. His creatinines were in the 4 at baseline. He is planning to start dialysis in this relative soon future, so we gave very little contrast. So we were trying to give less than 70 cc's was our goal. And as you can see, there's a very tortuous bend. It's a lot of these Lima grafts, and it can make it very difficult to wire. And these are from the diagnostic images from the outside cardiologist. So he's a 6 French IMA guide. We were able to get our Manamo guide wire down actually very easily. We did have to pre-dill. We tried to direct stent it. We couldn't deliver the stent down there. We had to pre-dill, put a stent in, and we got a great result at the end of it. Any questions for me?
So one question on that particular case is, did you use a 90 centimeter guide?
I
You
can't remember. I can't remember.
So the answer is you have to, because you're not going to reach otherwise, right? So IMA interventions where you're doing anastomosis in the native or beyond, you will not reach. If you have a 110 centimeter guide, you need to use 90. You see all the pleating. The Manamo is an extremely, gentle wire. And look at the pleating of the Lima proximally, okay? You could almost have enough pleating where there's no flow. And you're going to know when you have no flow in a Lima, right? Because the STs are going to go up and the patient's going to start complaining. But more importantly than just that pleating, if you had put a wiggle or a grand slam or that, there would have been so much pleating that devices, contrary to what we think, are more difficult to pass than if there's less pleating, right? Because we have pretty low profile stents. But if you have so much pleating where it's crumpled, the stent's not going to go down. And this is the big challenge of IMA intervention, because you push and pull too much and the guide gets sucked in, you're going to dissect this mammary. And that becomes a whole different kettle of fish. So this is a very interesting days gone by, he made it look easy. These are not easy interventions because things will not go this smoothly. But again, you've got enough support in the back, you've got nitinol in the middle, you've got a friendly, Act 1 tip. So it doesn't cause bleeding, yet it supports you, and you get the case done atraumatically. Right? Typically, what I would do in days gone by is I would wire with a workhorse, put a turnpike LP down, switch to a supportive wire like a wiggle wire, because I don't want things to move around, and hope that I don't have so much wire bias and crumple that I can get my product down. Okay, but here, you've got a workhorse wire that accomplishes all that without harming the vessel. So it's a nice demonstration. Any questions? Yes. It's really purely for torque response and durability, okay? It does not, again, it's still a 0.5 gram. And I'm not going to say never, but BMW, Xi'an Blue, Manamo, you very, very rarely will have an end perf unless you really push this thing and don't keep an eye on it. Whereas Fielder XT, Xi'an Black, Pilot families, you let those wires go, they're going to go. They're polymer jacketed and they will go through small vessels. These are extremely safe. Any questions on that? Okay, great, thank you. All right, and next step, we've got Dr. Chima, who's going to talk to us. The Xi'an Blue guide wire.
Okay, last but not the least. So now up till 1:15 p.m., you guys have a lot of guide wire education, 1 lecture in the morning and 2 lectures right now. So now is the time to do the post-test, which like 80% of questions should be right in order to get the reimbursement. So let's get started. Just kidding. So let's get started. Xi'an Blue wire. No disclosures. So a little bit about me. So I did my internal medicine residency and then chief residency and then cardiovascular disease fellowship in Philadelphia, Thomas Jefferson University Hospital. And then I moved to University of Arizona for my interventional cardiology fellowship. And next I'm going to Ochsner in Louisiana. So as you can see, like I have touched 3 corners of USA, and it's more predictable where I will be next. So west part is left. So it's predictable, right? So that's how your workhorse wire should be. It should be very predictable. And in challenging cases, when nothing is going with you, you want your wire to be with you because God knows what is the next case. You are getting tortuous vessel, calcific vessel. So you want to team tag your best team so that you have the best result for the patient. Okay, as Dr. Parikh mentioned, there are gazillions of wire and it is very difficult to comprehend each and every wire. So what you need to know, maybe a couple of guide wires, and then when you start practice, then you can actually choose your own wire. So identify your workhorse wire, and this is like the analogy which I picked up. So you can see like all the persons that are sitting on the chairs look the same, right? So just imagine these are your guide wires. So from bird's eye view, they look the same, like everyone is wearing the same color coat, they are sitting on a good chair, and except for the middle 2%, rest of them, or at the extreme left one as well, rest are like crossing their legs, but mostly they look the same. But if you look closely, only one of them is your workhorse wire. So you want your workhorse wire to be there whenever you are dealing with very difficult lesion. So what is the purpose of guide wire? Like my educational part will be very brief because you guys have already given a lot of education on guide wire. So you want to get the job done, as simple as that. And job should be done in atraumatic fashion, and the wire should be able to cross the lesion without any difficulty. Tortuous vessel, as Dr. Prasad mentioned, if there is very tortuous vessel, there will be wire bias, so you want to minimize that. So you want to have a guide wire which gets the job done. So all those things, to track through the vessel, to access the lesion, and to deliver your gear. Gear could be balloon, stent, guide liner. It's not the wire, actually, it's everything together which gets the job done. But getting a good guide wire down the disease vessel, that's one of the main thing, actually the fundamental thing, because that's the first step of doing PCI. Okay, what are your frontline guide wires? You already know this is Asahi's talk, so I'll just focus on Asahi. So Xi'an Blue, it depends like which area you practice and what is the workhorse wire of your attendings. But I would say, like I have been in two training institutions, around 70 to 75% of attendings use Xi'an Blue as their workhorse wire. So if like majority of the people are using that, then the jury is out, like which is the best wire which gets the job done. And if you are dealing with any complicated lesion, then there is whole menu of the menu on the table as far as the guide wires are concerned. More support, you use Grand Slam, and if you are using multi-vessel or doing multi-vessel PCI, you can use other wires in Xi'an family as well. Just by show of hand, how many of you are doing interventional fellowship? Oh, so almost 40%. How do you pronounce Xi'an? Is Xi'an or Xi'an, or it's a mixed, or Sion? So actually the survey was done on that, and correct pronunciation is Xi'an. Perfect. So Xi'an Blue specification, I won't spend too much time on that, but I just want to tell you three things. So Xi'an Blue, the unique features of this wire are the tip is actually hydrophobic, because you want to have the tactile feedback. If it is hydrophilic tip, like water-loving tip, it can go anywhere and you won't have that tactile feedback. So the distal 1.5 centimeter is hydrophobic coating, so that you can get the tactile feedback. And proximal to that, it's the hydrophilic coating, so that if there is any tortuosity, calcific lesion, had it been hydrophobic, you would have all the troubles in the world to navigate that wire in that calcific tortuous lesion. So tip is hydrophobic, proximal to tip is hydrophilic. And it is 0.014. It comes in two lengths, 180 centimeter. If you are working with like CTO word, or you are doing any high-risk PCI where you want like with the rotafloppy wire, it comes in two lengths, 180 and 300, so that you don't have to use trapper balloon. And the tip load is 0.5 gram. And this is the tip load you want your workhorse wire to be at. If it is more than that, then the chances of perforation, dissections go up. And as like Dr. Parikh mentioned, Act 1 technology, this is the unique feature of Asahi wires. Act 1, if you don't remember anything on this talk, just remember that Act 1 actually makes Asahi wires more torqueable, more durable, and they get the job done. And this is the last time, or the only time, you want one in front of ACT. Otherwise, if you see one in front of ACT, IV line is not working. Okay, Xi'an Blue construction, enough has been said of that, and I think you will be saying this thing. But whatever engineers have done for us, I think they did a remarkable job. And as they say, seeing is believing, but I would add to that, seeing and feeling is also believing. So there is Asahi booth outside. So If you want to actually check that how the different guide wires feel like, is it one-to-one torque or I'm just making up the stuff? So just get and do that stuff and you will see like this wire is actually different from the other wires. Act 1 already been done. More durable, get the job done, and one-to-one torque response. Okay, I'll skip that in the interest of time. So tip durability, as Dr. Prasad mentioned, you can like shape your wire multiple times if you are doing multi-vessel PCI. So these are the other two contemporary workhorse wires, BMW wire, run-through wire, and if you use them multiple times, like you can see there is some deformation of the shape, but Xion Blue maintained its shape, and the reason for that is ACT1. And this is like the cartoon diagram. If you go to Asahi booth, you will have a chance to play, and actually there is a prize if you can cross the lesion in less than 90 seconds. So it has been aggressively treated, or not treated, aggressively crushed against that end hole, and even after that, it maintained its position. And this is the like a chart where you can see that if you are distal to the lesion, you want your torque to be transmitted all the way to the distal end of the wire, because that's where you want the wire to go either into the diagonal or small branch. And with the other two wires, you can see that it's not a linear relationship, but for the Xion Blue wire, it's closer to ideal. It's like ideal is like you can see it's right across that, and Xion Blue is right below that. Very hard to believe, but once you use that, feel that, it's actually true. And that's what it feels like, torqueability, one-to-one torque, and you can challenge yourself if you want to cross the wire from the first hole, second hole, and this is all due to that engineering technology, ACT1. Good. Okay. So shaft support, it's more as compared to other wires because you don't want your like how many have you worked on a Omni wire? Very crappy wire. Like sometimes you do IFR, you are thinking that it will be negative, but it turns out to be 0.72, and then you are surprised. And then you want to do PCI. If you do that on that Omni wire, you will feel that that's not a good wire to work at. So you want to have a good shaft support. Okay, as Dr. Parikh mentioned, Xion Blue, it comes in different color as compared to other Asahi wires, so that you can easily distinguish those wires whenever you are doing multi-vessel PCI or you want to protect a side branch. Summary, and let's go to cases. I have 4 minutes, so I'll try to do these cases quickly. So both are RCA cases, so let's go to the first case. Okay. 83-year-old man, he was brought to the hospital for exertional chest pain. He went to his like cardiologist, he had some pains, he has like chest pain and symptoms, and outpatient stress test was recommended, which showed that there was some disease. There was a plan of doing PCI, but he got admitted beforehand. So he was brought to the hospital, with chest pain, and next day he had a cath done. He had minimal elevation of troponin, like high sensitivity troponin were in 60s to 70s. He had paced rhythm, so this EKG is like you want to apply Scarbosa criteria, you can, but okay, so we went with radial first. As you can see on the extreme left angiogram, there are two catheters in. We went with the Tiger catheter from radial. There was accessory radial artery, so we were having difficulty in torqueability of that Tiger catheter, and patient was having pain as well. So at that time, we decided to go femoral route. So first we tried with 6 French JL 3.5, and we injected the left coronary cusp. We can see the calcium moving, but we didn't see any left main coming from that. And we knew that we are dealing with either like very ectopic left main, or it's not the right catheter to engage left main. So we went with a bigger catheter. didn't get anything from the left coronary artery. And then RCA, same problem. So then we went with the pigtail catheter, did the aortic root shot, and we saw there was something coming from the right coronary cusp. And we tried to engage RCA with AL.75 catheter, and this is what we got. So you can see left main is anomalous, and RCA is diffusely diseased. Even before the injection, you can see there is calcification present on both sides of the vessels. And even the RCA ostium is involved. So ostium, mid to distal RCA, it was diffusely calcific disease. And fortunately, like on angiogram, left system look okay. So at that time we stopped, we had discussion with the surgeon, and they said that patient is too high risk for surgical intervention. So we planned PCI, high risk PCI. We went in with Impella. His EF also dropped. It was 45 like before, and it was 25 when he was admitted to the hospital. So you want your best team for this case, not in terms of like techs, fellows, but as far as the equipment is concerned. So we went in with a microcatheter and a Xi'an blue wire. It was like very calcific vessel, but we were able to navigate through that calcification tortuosity without any difficulty. And then we went with rotablation, did the rota of proximal and mid portion. We didn't cross that mid to distal like calcific lesion, because that's where the perforation chances are maximum. So after that, we exchanged it with our workhorse wire Xi'an blue, and we were able to put a stent in distal RCA, mid to distal RCA. And then we had to use the guideliner because it was difficult to deliver the stent down there. Then there was time to put the stent in ostial to proximal RCA. And as with any other bifurcation, you want to make sure. Oh, I'm sorry, guys. I'm taking. So yeah, as with any other bifurcation PCI, you want to make sure that your side branch is protected, and this side branch was left main. You never encounter that, so you don't want to jeopardize that left main. So you see the other wire. So that's where the different coloration of Xi'an family comes into play. So we went in with the Xi'an wire. Okay, and result was good. Just five minutes if I can get 5 minutes. The other case is very interesting.
They're very unforgiving with these times.
Door to balloon. Okay, so we did IBUS of left main, and left main looked okay. So we deployed that ostial to proximal stent. We pulled the wire before deploying the stent because last thing we wanted that wire entrapment, but that didn't occur, and this was the final result. 4024. Everything was done with IBUS, so good result. And patient lived happily afterwards. Okay, case 2. Just quickly, 3 minutes. 69 male of women. She was presented to the brought to the hospital with chest pain. Past medical history, as you can see, classic risk factor plus DVT-PE on Xarelto. Hemodynamics okay. You can see here inferior STEMI. ST elevation more in lead 3 as compared to 2, so it is RCA. No like ST depression in V1, V2, V3, so less likely to be posterior or circ. So as we expected, we went in with Tiger catheter. Tiger catheter is a good catheter because it saves time. You can engage RCA and left main like without any guide exchange or without any catheter exchange. So there was something in proximal LAD. It's overlap with circ, but nothing bad. So we were having difficulty engaging RCA, but then catheter quickly went into RCA, and this is what we got. So first, I thought that my attending who was just next to me because he said, I thought that he will say, you are fired from fellowship, you caused dissection. But the patient came in with inferior STEMI. So, and in the next shot, you can see that actually the proximal portion of RCA looked okay. So it was acute plaque rupture, which caused dissection. So not all dissections are scared. So atherosclerosis can also present with dissection. So in this type of scenario, you want to have a wire which can get the job done in atraumatic fashion instead of extending the dissection. So we went with our workhorse wire, which is Xi'an blue. It went in easily, and you have to like wiggle the wire so that it is free, the tip is free, it's not into the subintimal space. Then we went in with IVUS catheter, and I want you to look at this IVUS for 15 seconds. We are in mid RCA, and then we are coming back. And here, just see at 10 o'clock, you will see something coming. This with chroma flow on, you want to see like where the dissection starts and ends. So at 10 o'clock, you can see the distal entry point of that dissection. Now we are coming to the lesion. If I can forward that. And here you can see the dissection ending. So you know where the dissection started and where it ended. 10 o'clock, 10 o'clock. And it was 10 p.m. at that time as well. So, okay, so we went in with 3.0 times 26 millimeter stent, and final result was this. Okay, so last slide, bottom line. So wherever you go, wherever you practice, just have your workhorse wire, and workhorse wire is a wire which gets the job done in a traumatic fashion. And you have played this game, I think, maybe 5-6 years ago. So you want to select a player which is reliable, which you have victories before. So in that, like all the wrestlers, you will go with your favorite player whenever you are against the devil. So just apply that in coronary word. Whatever challenge you are faced, start from the basics. But what is the wire which gets the job done for you? And you will be successful. Thanks for that.
So I'll close out in a minute, so you have some time, but I want to take some questions. So I'm going to pose another question. If the first wire, your Xi'an blue, as great a wire as it is, went subintimal, what would you have done next?
That's difficult. If it is subintimal, I would have kept the wire there and went in with a different wire and tried to be in the true lumen, because that wire is telling me, don't come near to me.
And that's the right answer. So you leave that first wire where it is. It's parallel wire, right? Second wire is less likely to get into that same false lumen. And you can take a second Xi'an blue. Okay? Slightly smaller bend, and you navigate down. If I was in this case, I would always do a support catheter behind it. You didn't. It's okay. But if I was subintimal with the first wire, I would definitely take the second wire with a support catheter. So once I'm through, I would spin through and switch out for something more supportive if I needed it, or a long wire. But that's really the answer, and it's the answer. You're going to get into the situation. You want a wire in these STEMI situations that is safe, because you do not know what's on the backside of that occlusion, whether you're in a diag, whether you're in a septal. Don't start ballooning until you know that you're safe, that your distal wire is where it needs to be. There's a thing called wire tip stress. What does that mean? Your brain has to be programmed for that. When you see a workhorse wire deviated or bent in an awkward way, it's in the wrong place. You need to pull back and release that stress. Okay? And you will start thinking that way as you do these cases in the lab. And these wires are on your side. They will not hurt you. They will get cases done that in days gone by we used to really struggle with. Any final thoughts? So from our clinicals that are here, I'm curious. The Manamo over the Xi'an Blue, clearly we understand the engineering differences between the addition of nitinol, okay, versus the Xi'an Blue that does not have that. But from the standpoint of marketing, right, everything has a dollar figure, right? How much engineering did you put in? Or what's your return on investment? What was the rationale for the Manamo as an added tool to your tool bag? Anybody? Give me some credible answer. Just curious, just so we can learn together. Because I think it really just shows the commitment that Asahi has as a technology company to this space.
I think that's kind of where we were as commitment. So we realized that Xi'an Blue and other wire technology is what it is. And bringing Manamo, which is something very unique, it's a hybrid wire. It's something that physicians had really requested. We need something with nitinol, but stainless steel that's very effective, and it creates efficiencies within a case. So that's exactly what Asahi does. They listen to yourself and to other key opinion leaders in the space, and we develop what you ask us to create, and we do it all in-house from the beginning to end. Asahi owns it all. So that's what we try to accomplish, and I think we've done that with Manamo. Xi'an Blue is very successful, as well as Manamo's been a really impactful wire for our space.
Fantastic. Again, it takes the market of BMW. There are BMW diehards, nitinol wire, right? So here now you give them in a BMW user's hands the powerful technology of Act 1 and the Xi'an Blue, but with nitinol in the middle, which has similar feel, even though it's not at the tip. Yes?
How does nitinol help you, or what does
So nitinol has memory. It reverts back to the shape you initially had. That's the beauty of why we use BMW in the first place. It was fellow safe, right? You can mangle it and it comes back to life. And you weren't going to perforate or dissect in the hands of a fellow wiring basic workhorse lesion. Yes.
So one last thing before we close out, too, just so I don't forget, is that we had a lot of brochures and a booklet up here with all of our wire and technology. They all kind of disappeared very quickly. So if you want to know more about Asahi wires, there is an Asahi InTech app. You can download that, and that way it's at your fingertips. So just want to finish up
That would
with
be good
that.
to have the QR code so they could get that. Last question.
Is there a new skill for guide wires without coil, like choice PT?
I mean, there is. There are people who love Choice PT. The problem with Choice PT is once you get it to where you want to get it to, and it's pretty good, you got to get it out. Choice PT should never be your workhorse wire, and I'm sure you've got attendings who use it, and they won't tell you about the perforation. Because that's the problem with that. Okay, thank you, everyone.